volume up on this thing.
Do you need help?
Yeah. How you get the volume up on this thing?
It's muted.
Well, right now it's good. Turn it down.
One of the tablets for the
Okay, Kim. Okay. Watch this. There you go. Good work. Now, Kim,
just a little bit. No.
why are you so forceful, bro? Like you're gonna appreciate. You're gonna take my class, whether you like it or not.
So the blood pressure falls, the meta-arteriole in a non-essential capillary bed constrict.
Wait a minute, let me back up a little bit.
Thank you. Bedtime. I love looking at old videos.
I like where you go away today with a few concepts
Yeah, be quiet so you can hear this.
that you can use in the way you think about shock. And first of all, I'd like for you to key in on that portion, the cellular aspect of the shock is. Because that's where shock really is taking place. And as you view this film, it will become apparent to you that that's a very important criteria and consideration that you want to make part of your repertoire. Normally we think about shock as an organ failure. The first thing we see early in shock is a loss in blood pressure. Immediately, early clinicians ran to support the blood pressure. Later, when they found that just supporting the blood pressure wasn't going to be adequate, and there were other considerations, different modalities were added. But the bottom line is, if we don't preserve the cellular function in the total body, we're going to lose the battle against shock. Early in that episode, as blood pressure falls, the meta-arterioles in the non-essential capillary bed constrict. This meta-arteriolar constriction is brought about by the release of epinephrine. It's a normal, good response to shock. And early in shock, that's what we want to do. We want to preserve the blood pressure. As this time interval, though, lengthens from the early constriction of the meta-arterioles, then the tissue gets robbed of oxygen that's not being oxygenated. And these tissues that we're talking about compose about 80% of the body. The vital organs have blood shut into them by this mechanism, so they stay alive, the heart, the brain, but other areas, skeletal muscle, the intestinal tract, the kidneys, those become ischemic. And in an lack of oxygen environment, those cells begin to deteriorate. As we look at the cells along capillaries, normally those cells fit very tightly. They allow partitions of nutrients to flow from inside the capillary out into the tissue. And white blood cells in a non-shock situation deform and they pass around the nuclei that make up the endothelial lining. When you deprive them of oxygen, though, the metabolism changes. And those changes that begin end up with edema in those cells, and those tight pores that you'll see in the slide tend to spread. And you begin to lose not only fluid, but protein, and eventually you can even lose white blood cells from that vascular compartment out into the tissue. As we continue to lose fluid out of the vascular compartment, this hypoxic environment leads to the degeneration and death of the cells that no longer have oxygen. The first thing that we'll see is the cell membrane begins to bubble. In the electron micrograph, you'll see this demonstrated, and the byproducts that are generated are toxic and are then picked up by the general circulation. In the film, if you'll watch carefully, you'll see this loss of fluid from the capillaries. You'll see the total change in the tissue structure of the lung. And I want you to remember, this is happening in other tissues besides the lung. It happens in the long intestinal tract. It's happening in the kidneys, and it's happening in the liver. And all of those have consequences as to what it is we're going to be trying to treat as we use shock in a larger, broader space than just survival. Survival is very important, but it's my contention that if we don't support the other systems and prevent the tissue damage, it does us absolutely no good for the animal to survive, to die 2 weeks later of kidney failure because we failed to provide adequate perfusion to the kidney. Or the next day, having sluggish intestinal lining in a pool of hemorrhagic diarrhea. Those things happen, and they're preventable, and they should be included as part of the way we view treatment. Doctors Wax and Webb developed this extraordinary technique enabling them to take motion pictures of the microcirculation inside the lung. Watching the film as you see those things happen, and remember, early treatment is what we're aimed at.
Here is a section of the dog's lung at a magnification of 150, which gives us a field 360 microns wide. Despite a slight motion from breathing, we can plainly identify an alveolus, blood vessels, even red blood cells, which are only 7 to 8 microns in diameter. Now, at a magnification of 300, we can easily see the capillary blood flow. We can even see a microphage. The field here is approximately equal to the thickness of 2 sheets of paper. At a magnification of 450, where the entire field is only 120 microns wide, we can clearly see even smaller structures, such as white cells. And we can observe the pulsatile flow in the capillaries. To study the microcirculation in shock lung, Doctors Webb and Wax used anemic but otherwise healthy dogs subjected to hypovolemic shock by bleeding into a plastic reservoir to a pressure of 40 millimeters mercury. This is a picture from the superior aspect 15 minutes after hypovolemic shock. The most obvious change is an immediate loss of capillary blood flow. Still viewed from the superior aspect, this is the condition after 2 hours. Now we see interstitial edema between alveoli and around blood vessels. Note that the blood vessel walls are widened, encroaching on the alveoli and on the lumens of the blood vessels. The red cells stick to the endothelium and also pass through vessel walls into the interstitial tissue. This accounts for the red coloration. The animal has now been reinfused with its own blood. we see that the capillary flow has increased, but even after 1 hour, the extravasation and other damage persist. So far, we have observed the changes in the superior portion of the lungs, but gravity itself plays a major role by increasing hydrostatic pressure in the inferior areas. Let's look at what is happening there. 15 minutes after the onset of hypovolemic shock, the inferior area shows little damage. Capillary flow is reasonably good, but begins to become sluggish even as we watch. After 2 hours, the damage in the inferior area is more pronounced. Interstitial edema and extravasation are evident. The basement membranes of the alveoli are thickened, and the alveolar spaces are mottled, not sharp and clear as before. This is a characteristic picture of congestive atelectasis seen in the shock lung syndrome. But the dramatic differences in the inferior area occur after reinfusion. Here, gravity has added to the congestion. Clumps of platelets and white and red cells have blocked larger vessels. Alveoli are collapsed, without air, atelectasis. Overall, extremely damaged tissue, more apparent in inferior portions of the lung. Patients sometimes are given a vasopressor without sufficient volume replacement. This is what happens in the dog lung under such circumstances. We see the greatest damage yet: diminished blood flow, edema. We can see atelectasis develop as blood vessels surround and squeeze down the alveoli. Obviously, a vasopressor can cause irreversible damage if administered without adequate volume replacement.
Everybody know what a vasopressor is? Epinephrine, things like that. Norepinephrine. Drugs that will cause this vasoconstriction, especially in the mid-arterioles. There are a number of things that will do that.
I think as we begin to understand the mechanisms that are taking place in shock, we can appreciate what we're trying to do with treatment. And the early treatment we talked about before keys in on the fact that it helps those neurons can provide and do provide, but
and the blood vessels are filled out to their periphery. In the dog lung, 1 hour after the corticosteroid and reinfusion, the alveoli have become clear and distinct. We have blood flow completely across the vessels and a minimum of residual extravasation. At the cellular level in the dog lung, the analogous picture is one of healthy lung tissue with little or no residual damage. Virtually complete lung tissue recovery in the dog within several hours. However, without the full program of monitoring and therapy, we might well expect that we would have seen the same picture that we saw earlier in this film in the untreated, reinfused dog. A picture of shock lung that could be, and so often is, fatal.
The treatment was
I'm amazed every time I look at that.
corticosteroid. That's the treatment.
It's utterly amazing to me to see that white blood cell move across the screen in front of us. I'm also amazed that corticosteroid therapy continues to be listed as a controversial mode of therapy. Clinics in North America, the November edition, places it in that category. And in Goodman's discussion of septic shock, he cites studies that both prove and disprove the value of steroids as a useful therapy. He cites Leonard Henshaw's recent study of 223 patients in severe septic shock that did not show any statistical differences between treatment and non-treatment. He cites the Bone study that showed an increase in secondary infections following use of corticosteroids. And then comes right back and talks about Bill Schumer's study of 500 patients, a prospective study, that the treatment was identical with the exception of inclusion of corticosteroids, the proper corticosteroid. 40% of those treated with steroids survived. 12% of those not treated with a steroid survived. I began to get a picture as I listened to this, though, of why these differences occur. And I have to go back. I can easily understand if we wait till late in the syndrome, while we could when the host defense mechanism is impaired, why we would see differences, why we would see no benefit. If steroids are to be a benefit in therapy, they have to get to the cell before it's damaged and before it's beyond repair. Goodman also points out that the type of steroid is going to be very important, that we choose a water-soluble ester. He points to the Gary White study that showed without a doubt that the succinate, the water-soluble succinate ester of prednisolone, markedly outperforms the water-insoluble substitutes or other steroids that are used. This early therapy, combined with proper volume replacement and proper management of the patient, can lead to survival. But I think we need to come back to this cellular component of shock. Shock is a cellular event. And although we certainly need survival as our primary target, the protection and maintenance of all of the cells and tissues in the body are very important considerations as we consider treatment therapies in shock.
All right, questions? First of all, why do you think water-soluble steroids make a difference? Yeah, because that's what's going to make it really accessible to the tissue. As we think about steroids, what's the nucleus of a steroid? Cholesterol. And that's a lipid. Is lipid very soluble in water? Pour some oil on water and see what happens. So that's what he's saying, that you have to do that. Now, one of the things you have to take in mind, keep in mind when you're looking at a film like this, what's that first name that came up there? Upjohn. What's Upjohn? It's a drug company. What do they make? Take a wild guess. Steroids. Is especially, well, the one that they started with that was such a world beater was a drug called Soludelta-Cortef. And why they call it Solu is because this was really a water-soluble steroid, the first one. Now, the ones he's talking about here are later generations than that. But that's why they claim it's so important. Of course, you have issues with septic shock as versus steroids. And why do you think that's such a problem? Maybe a problem. We're not talking about cardiogenic shock or anaphylactic shock from you getting a bee sting or something. You know, we're talking about septic shock that's due to actually a biological agent, most of the time gram-negative bacteria. So why do you think steroids might be contraindicated there? What do steroids do as far as your ability to, they immunosuppress it? Now, is that necessarily going to be something that's that terrible, or what can you do to try to get around that? Come on, my clinician, you all come up with something. Antibiotics. So you make sure that you do that. It's important to assess what kind of shock you have, and to administer the proper therapy as early as you can, and make sure that if it is a septic shock and you are giving steroids, that you cover that with antibiotics. Now, how do steroids really help as far as all of this stuff is concerned? What's the big thing that they do? They stabilize membranes. Okay. Now, do you remember seeing anything in this film that resembled anything you had already? What about the constriction of the arterioles and the compensatory response? Yeah. We talked about that. And when he's showing you cell injury and showed you that scanning electron micrograph, what's that showing? Cell swelling or blebbing of So this film is just to help you understand more about what's going on, especially from the shock level, because most of you are not in here because you want to be a pathologist. Most of you are in here because you want to be a clinician. And you need to learn how to treat this stuff, and you need to start learning to do it now. Yeah.
So when they had them in lateral, right?
Yeah, in lateral recumbency, yeah.
So would it be safe to say to avoid atelectasis or the damage, the extensive damage of atelectasis, if you had a shock patient, instead of leaving them in lateral, trying to do everything, sitting them up sternal would help decrease the amount of...
Well, yeah, it would, but what's wrong with sitting them up sternally?
Someone's gonna prop him up.
Well, not just that. But if I sit him up sternally, if he's like this, and this part is damaged, then I sit him up like that part is damaged. So the idea is not just to sit him up, but to move him, okay? So you don't just do that, but you do that and back, you know. That's the idea, to keep moving them around so that you don't have that problem sit. Because if you just put him in another position, something else is going to be dependent. See what I'm saying? Okay, yeah.
I'm okay, never mind.
Any other questions? Well, one other thing too is if you want to see this again, I will load it up to. I think I can get it loaded up on Blackboard so that you can view it up there. Okay, and that way you can do it at your leisure. But I wanted to make sure that everybody got exposed to treatment of shock, because you're not in here just to learn what is shock. You're in here also to learn something about what you do about it. Okay. Where's my roll?
It was never passed around.